Welcome to this video on the approach to non-traumatic shock. Our clinical objectives are to define shock beyond simple hypotension and classify the four main types of non-traumatic shock. We will also standardize initial stabilization and integrate POCUS, or the Rush exam, into the diagnostic algorithm. Shock is defined as a state of cellular and tissue hypoxia. A critical clinical pitfall is equating shock with hypotension, as compensatory mechanisms can mask it. Focus instead on markers of end organ perfusion, like lactate, mentation, and urine output. The four main types of shock are hypovolemic, such as from non-hemorrhagic fluid loss, cardiogenic due to pump failure, distributive caused by vasodilation often seen in sepsis, and obstructive resulting from extracardiac obstruction. The shock index, calculated as heart rate divided by systolic blood pressure, is a key tool for early recognition. A value greater than 0.9 is a critical threshold, highly suggestive of occult shock, and predicts mortality better than vitals alone. Initial stabilization follows the ABCs. Maintain a low threshold for intubation. Provide high-flow oxygen, avoiding NIV in severe shock. Establish 2 large-bore IVs or IO access. Be judicious with fluid challenges, restricting them in cardiogenic shock. Hemodynamic profiles vary by shock type. Hypovolemic and obstructive shock generally show decreased cardiac output and increased systemic resistance. Distributive shock presents with very low systemic resistance. The rapid ultrasound in shock, or Rush exam, is the bridge between resuscitation and diagnosis. It assesses the pump for contractility and size, the tank for fluid status, and the pipes for obstructions like aneurysms or DVT. Key diagnostic markers include lactate, the most important prognostic indicator, with a normal level less than 2.0. Base deficit greater than 4 is significant. SCVO2 greater than 70% indicates adequate supply-demand balance, and procalcitonin can aid in early sepsis differentiation. Comparing mortality across etiologies, cardiogenic shock has the highest mortality at approximately 50%, followed by sepsis at 40%, obstructive shock at 30%, and severe hypovolemic shock at 25%. The management timeline is structured. At t equals 0, perform ABC stabilization and calculate the shock index. By t equals 15 minutes, complete the Rush exam and a fluid challenge. At t equals 45 minutes, initiate empiric antibiotics and vasopressors if needed. T equals 60 minutes is the goal for definitive care. To conclude, remember the definition from Rosen's Emergency Medicine. Shock is not a blood pressure. It is a lack of perfusion at the cellular level. Thank you for your commitment to excellence in emergency care. Please feel free to reach out with any questions. These are the image sources used in this video.